We are here to talk about COPD. I have an outline and some topics that I want to cover, but I want to be clear that everybody should feel free to ask questions at any point during this, and I will try not to use our full hour so we have plenty of time for questions from the audience as well. But you don't have to save your questions to the end. If they're, related to the topic at hand, feel free to ask them at any time, okay? Everybody good? Okay. So, we are here to talk about COPD, and I'm sure you all know that COPD is an acronym. It stands for chronic obstructive pulmonary disease. And that is really, as far as medical stuff goes, a pretty straightforward name for something, nothing too fancy. It's a chronic condition. It involves an obstructive problems of the lungs, which I'll explain more about in a minute. Lungs is pulmonary, and it's a disease, so it's chronic obstructive pulmonary disease. So that's what COPD literally is. So when you talk about COPD, it's not literally sort of just one thing. If you say that someone has COPD, that's not totally specific about what they may or may not have. There are three sort of main categories, but it's important to know that it's not like these categories are like strictly separated from each other. There's a lot of sort of blending across these categories. It's like, so there's one category is asthma. Asthma is technically a type of COPD. I think for the purposes of this talk, we may have another talk that's just about asthma. And so for the purposes of this talk, I'm not going to focus on asthma a lot, but I think it's important that everybody knows that asthma is technically a type of COPD. The next type is chronic bronchitis. And we'll talk a little bit more in a minute about what exactly we mean when we're talking about chronic bronchitis. And then the last type, which people probably have heard of, is emphysema. Okay? And so emphysema is another type of COPD. So like when you see your doctor and they talk about COPD, a lot of times when we're putting in our notes and when we're talking to other doctors, and oftentimes when we're talking to you as well, we'll try to be more specific. And if they're not being, you might want to ask your primary care doctor, if they say you have COPD, you can ask them, do I have more chronic bronchitis or emphysema? And like I said, it's not like these are strict, totally separated. They sort of, blend, the elements of them sort of will blend together. Okay. So, for the patients here, are all of you, is there anybody here who's a patient who does not have COPD? You do not. You do not.
I'm with him.
You're with him. Maybe strictly not a patient. How about you? You're not a patient. Are you just here for fun, or are you here with somebody else as well?
No, I've got asthma.
You have asthma and chronic bronchitis. Okay.
It wasn't really considered COPD.
Technically, if you have chronic bronchitis and asthma, then you do have COPD. But it maybe people sometimes confuse it, and they'll talk about if you had COPD, you had to have been a smoker. And that is not the case. Now, the vast majority of patients with COPD have been smokers. But I have patients with COPD who never smoked. And so some of those are people who started out with asthma from a young age and had significant asthma, and as time went on, the changes to their lungs that occurred because of their asthma started to look a little bit more like chronic bronchitis. That's what I talk about when we talk about that these are fluid across each other. We try to be specific about these, but there's a lot of overlap. I also have, and we'll probably be running out of them in 10 or 20 years, I have a fair amount of patients with, and most specifically with chronic bronchitis, especially here in Iowa, who are farmers and never smoked. And it tends to be, I hope in 30 years to not have those patients anymore, because the younger guys are growing up working in these big fancy $100,000 John Deere tractors that have the cab and everything. But back in the day, it was just you on a little seat exposed to all the dust and dirt that Mother Nature has to offer.
And the dairy barn.
And the dairy barn.
Closed up in the winter.
That's right. So I do see a fair amount of patients who never smoked but have chronic bronchitis because of farming. There are some other, talk about some work things that can cause it. So here in Iowa, farming is a big one. If you read stuff on the literature, they won't even really talk about the farming. But it's there. I mean, I've seen it. It's there. Another big one would be like welders, stonemasons. You know, it's all common sense things. If if it's a dirty job and you're inhaling a lot of smoke and everything like that, then you're at risk, to end up with this. So that's sort of as far as the definitions go. Any questions about this? Okay. All right. So we talked a little bit about some causes with the work and farming and dirty jobs and things like that. The other big cause, obviously, is smoking. So cigarette smoking would still be, number one. If people are heavy with cigars or with pipe smoke and everything like that, you can get it. But by and large, we're talking, cigarette smoking, just because that's the most common thing, and also because, the cigarettes themselves, it's not just, the tobacco and everything, and some of the chemicals and stuff in there. And so when we talk about smoking, and sometimes what your doctor will ask you is when we talk about evaluating for COPD, we like to talk about the total exposure to cigarettes. So, what we do is we talk about that, and we talk about pack years. Okay? So how many pack years of smoking does somebody have? And what that means is if you smoked, say you smoked three-quarters of a pack for 40 years, okay? That's what we call 30 pack years. If you smoke 2 packs for 30 years, that would be 60 pack years. Pretty simple. There are no strict numbers on how many pack years you need to have to end up with COPD. But we do know that in general, go ahead.
How does that relate then with chewing?
With chewing. Chewing does not have any involvement with COPD. Chewing, the main thing you need to worry about is cancer of the mouth and tongue. But chewing does not really relate in any way to smoking because it's not getting into your lungs. So we talk about pack years. I don't know if I have like a strict record, but I've definitely had people who are over 100 pack years, that's a lot. But I have patients who have 20 or 30, or sometimes even less than that pack years who have significant COPD. Especially, we got a lot of, there's a lot of guys who work in some of the factories and smoke. Not to disparage any of our large local employers, but the environment at ADM is certainly seems to be conducive to COPD, with just some of the chemical work that they have to do and everything. That's the sort of smoking part. But of course, not everybody who smokes gets COPD, right? So there are genetic components that give prevalence to making people prone to smoking. So if somebody's parents were smokers and had COPD, I would strongly advise their children. We don't, obviously I'm a lung doctor, I don't advise anybody to smoke. But certainly there are genetic components that are, to a large extent, not fully understood. It's not like we know which specific genes and can run, there's all this new stuff where they can map your whole genome and everything. We don't really have a lot to go on with that says, okay, these are the genes, A, B, C, D to E, to look for, to say, okay, this person is going to be at risk for getting COPD if they smoke. But we know that there are genetic factors that you can have one person with 80 pack years of smoking and they go and do their breathing tests and they live their whole life and they have no issues with shortness of breath or bronchitis or anything. And you have other people who, smoked a pack a day for 25 years and, are, needing oxygen or have severe COPD. There are genetic factors at play there. They're not totally understood, but we know, that if other family members got COPD, that you might be more likely to get it as well. There is one specific gene that we do test for in some patients. We don't test for it in all patients, but we do test for, in anybody who has emphysema, and we'll talk more about how do the doctors determine do you have emphysema or not. In anybody who has emphysema, which again is a type of COPD, we will do a test called alpha-1 antitrypsin. Okay, so alpha-1 antitrypsin is a protein that our body normally makes. We all make the protein. And it acts, like it says, it's alpha-1 antitrypsin. So trypsin is another protein our body makes. This is how our body often works. We make one protein, we make another protein to control it, so we keep a balance of things. And so trypsin is a protein that's designed to sort of break down damaged tissue so that the body can sort of have some other things to sort of self-repair, okay? If you have too much trypsin, you get too much tissue breakdown. Make sense? And so there's not any genetic thing where you make too much trypsin. What there is there's a genetic condition where people don't make the antitrypsin to control it. And I don't know if any of you remember from high school or anything like that, your basic genetics, but we all get one gene from both parents. The normal antitrypsin gene is an M. Okay? There are also C, F, S, I, there's a bunch of them. So a normal person gets it and they get their genetic testing and it says it's M. That's normal. Okay? We run some people and we get it and they get an M and they get a Z. So one of their parents gave them the Z. The Z, you don't make the protein, it doesn't work. So if you're a person who has an MZ, you only make about half as much of the antitrypsin as you need, or as you're supposed to, but it turns out it's mostly enough. And these people don't get rapid emphysema or anything like that. But some patients end up with ZZ or ZS or some other combination. This is the normal, these are all abnormal. some combination of two abnormal versions. And if they have this, then they get real bad emphysema, often real fast. If they smoke at all, they're going to get it. Some people, even if they don't smoke, can still get emphysema if they have two bad versions of this gene. Go ahead.
Is that a blood test?
It is a blood test. You can do, there are certain blood tests that they'll run through the lab here. There's also, in the clinic, we have free versions from the company, from companies that make we can do a free check where we just do a blood test of your finger in the office. Turns out the lab test for this is actually quite expensive, but the company gives us free test kits to use on people, because it turns out that there are drugs that you can specifically give that basically mimic the alpha-1 antitrypsin. They make it chemically, and people come in and get infusions. None of you have this, by the way, do you? Anybody? So we have a few patients who have alpha-1 antitrypsin deficiency, and they come in and they get an infusion once a week to replace the protein. And it turns out that's a really good business for the drug company, and they make a lot of money off the insurance company, and so they have a vested interest to make sure that us doctors aren't missing any diagnosis. So they give us the free test kits. Nothing's ever really
Why
free.
doesn't everybody that's got COPD get these tests?
So anybody who has emphysema should have the test done at some point. Of all the patients who have emphysema that I test, it's probably like 1 in 200 or less that actually have the enzyme deficiency. But if you have emphysema, you should get the test. Now, if you don't have emphysema, if you have chronic bronchitis, then you don't need to have the test. Does that make sense? There is definitely a strong argument, and you can find this in everything, that in general, this test should be done much more often than it is done generally in practice. Okay? This was impressed upon me by one of the professors at Iowa who's very knowledgeable in alpha-1, so I do try to test a lot of people. But it's definitely, if you ask the National Board of Pulmonary Doctors, are we as doctors in America running enough alpha-1 antitrypsin deficiencies, they would all say no, that we are underutilizing that test. So, go ahead.
If you have a relative that has that or had that, who would you recommend you testing?
So it's basic genetics. So if you have a parent who has this disease, or even then you certainly should be tested. If you have an aunt or uncle who has the disease, you should definitely be tested. Any grandparents had it, you should be tested. If you have a cousin who has it, and you have any element of COPD, I would test you. Second cousins, I don't know.
This is probably a stupid question, but Dr. Painter told me I had COPD.
Mm-hmm.
I don't know which one of those three things I got at all.
So that's not a good question. That's a good segue, actually. So, how do you know? So, asthma, we mostly determine by, are you sensitive to being around cats and dogs? Do you have a lot of allergies? Are you allergic to being around perfume or scented candles or other strong smells? And associated asthma is typically associated with specific triggers, and it's also associated with asthmatics. Oftentimes when they get the Albuterol, they really like it. And or if they get one of the steroid inhalers, Asthmanex, Flovent, or the Advair and Brio all contain a steroid as well, they tend to really like those. So asthma is mostly sort of clinical, and we favor it if you never smoked. Okay, so, but the big question is, how do you know if you have chronic bronchitis or emphysema? I think that's kind of what you're getting at.
Yes.
So, emphysema specifically is a finding that in order to determine if somebody truly has emphysema, you either need to look at the actual lung tissue, like under a microscope, which we normally don't want to do. That would require having surgery to remove some of the lung. Or the bigger one is on a CT scan. Show of hands, who here has had a CT scan of your chest? Number, yes. So, if you have had a CT scan, we look at the lung tissue and you can see the way the lung actual tissue looks on the CAT scan. And in emphysema, the lung tissue is not as sort of dense as it used to be. If you think about it, the lungs are like a big sponge for air. They have lots of air pockets and everything. The air comes in, that's where the gas exchange occurs. And then there's tissue sort of holding those pockets together and tubes through there connecting everything. In people with emphysema, there is a significant amount of actual tissue destruction. So lung pockets that were there, you did have lots of little teeny tiny pockets start to get bigger because the tissue between them breaks apart. And so instead of having, you have literally millions or you literally have billions of these little pockets in your lungs. But so if you had a regular lung, or if you had a little area where there were 5 of them, in emphysema that 5 would become 1. And as that occurs, the lung looks less like a really dense sponge and more like a wholly old sponge that's been sort of moth-eaten out. And you can see that on the CT scan. And you really need to see that to be able to really say that someone has emphysema.
So it's, an X-ray of the lungs isn't going to show you any of that.
I don't think that we should make it from an X-ray. The radiologist will often get an X-ray and say that it looks like the patient has emphysema. And I would sort of have an argument with them that I don't think they should be doing that because you really don't have the resolution to see that on the X-ray. People with emphysema do have some characteristic X-ray findings, namely that as this is happening, the actual, if you imagine, your lungs, as this is happening, the lungs actually will get larger in general. And you can see that somewhat on the X-ray. It can sort of imply emphysema or suggest that there may be emphysema, but I would argue that the X-ray doctor should not be saying that that is emphysema. They could, and sometimes they'll put that on there. I don't like it when they do that. So, technically, I would say you really need a CT scan. Now, that is the technical way to make the diagnosis. That is not to say that we don't consider that some people have emphysema without getting a CT scan. If the X-ray strongly supports it, and the patient is very short of breath, and we have the breathing tests that show show a lot of lung loss, and that the lungs are much larger than they used to be, and that the gas exchange isn't good, you can put that whole sort of picture together and say, okay, I don't have the CAT scan, but I'd be shocked if I got it and it didn't show emphysema. There are some cases there are other cases where it's really sort of more unclear if it's more chronic bronchitis or emphysema. And like I said, people with emphysema can have a lot of chronic bronchitis symptoms, which is the chronic cough, the bringing up a lot of mucus, and things like that. And both people with emphysema and chronic bronchitis get short of breath. Okay? So it's not a strict barrier, but to really say it's emphysema, there are certain criteria that you need to have. And so I have some patients who I say they have COPD. I don't really have enough to say definitively if it's one or the other.
A few years ago, I left lung collapse.
Mm-hmm.
Got that home and she brought me into the hospital and they did surgery.
Mm-hmm.
And my bed, the doctor walked by and I said, well, what caused me my lung to collapse? He said, you got emphysema.
Yep.
And he said, there's no cure.
Those are all true statements. So, in people with emphysema, these holes, they can start to get really big. They can start to be like this much of the lung. And if they're on the outside like that, if you imagine, this is designed to be a little mini thing with a nice, good wall that holds together. As it gets bigger and bigger, the tension on the wall increases, and it can increase enough to the point in emphysema that in some people, that if that wall pops, you get an air leak. And then that's how you end up with a collapsed lung, because you're leaking air out of the lung into the chest and there's nowhere for it to go. And people with emphysema are more prone to getting these, and they can happen without any real trigger. We call that spontaneous. You can have a spontaneous pneumothorax. That's the fancy word for the collapsed lung. And that can happen in people with emphysema. And in emphysema, there's no way to reverse the emphysema that's happened. That is true. Other questions right now? Okay.
Is there a way to reverse chronic bronchitis?
There is not a way to reverse any sort of damage that's happened to the lungs. There are ways to minimize, sort of ongoing inflammation that is occurring. So we'll get to that in just a second. Before we leave sort of the diagnosis and this part, I want to talk briefly about the breathing tests. Who here has had a breathing test? Just about everybody. Okay, good. I've had a breathing test. They did it when I was in medical school. Fun fact, I was in a bad fire, and so I had some inhalation injury from that, and you can see it on my breathing test, that I have a little bit, not bad, but they're not quite normal. And they're not quite normal in a pattern that is very suggestive of somebody who had an acute injury like that. So it's interesting. So COPD breathing tests, we're talking there. When we do the breathing test, there are three different things that we do. One of them is spirometry. Okay. So spirometry is the one where the respiratory therapist yells at you to blow, 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 hard as you can, and you breathe into the little circle, and they have you breathe in as deep as you can, and then they want you to blow out as hard and as fast as you can. Does anybody know why they make you do that? Why do we want you to blow so hard? Okay, you're about to find out. So when we do the breathing test, the spirometry, there are three big numbers that we are looking at. One of them is the FVC, that is forced vital capacity. So that is a fancy term for how much air can you move. If we make you take as deep a breath as we can, how much air do you move in and out? And we measure that in liters as a strict number, and then we give it a percentage of what do we think you should be able to move based on your age, your height, your gender, and your ethnicity. Fun fact, weight doesn't have anything to do with it, but your height does. And these are, based on norms, that they take data from everybody and say, okay, what should it be? And then we measure what yours actually is. The other one that we'll do, and the reason you do the blow, 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 is we want to get your FEV1, that's forced expiratory, how much that's out, how much you blow out, volume in 1 second. So we want to know how much air do you get out in the first second of your breathing. So that's the FEV1 number. And then we do a ratio of these two numbers. We compare the FEV1 to the FVC ratio. Okay? So in patients with COPD, this number goes down first. This number goes down more than the FVC number. So that ability to blow air out in the first second is the first thing that will go. And so one, we can get that absolute number and see if it's decreased. And then we can also look at the ratio. And if the ratio is lower than it should be, and this number is lower, that's very suggestive that we're dealing with COPD. So somebody comes into the doctor, maybe they smoked, maybe they didn't. They say, "Doc, I'm short of breath. Can't walk up the stairs like I used to. Can't walk up the hill to walk the dog," whatever it is. We don't necessarily, we have some guesses as to what they might have based on talking to them, but you don't know anything until you really have some data. And so this breathing test is usually the first part of the data. And some people, has anybody ever heard of like pulmonary fibrosis? Has anybody ever heard of that? So in patients with pulmonary fibrosis, this number stays pretty good, but this number drops out. And so I'll do a little demonstration. So when we do the breathing test, we get an inspiratory loop that always just pretty much looks like that. And then when you guys breathe out, we get a graph of how the air moves. And that's what a normal one looks like. It's kind of like, it looks a little bit like a rounded sort of triangle where it goes up, 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 rounds off, and really comes down in a straight line. Okay? In patients with COPD, the up, up, up part will be about normal. But then what happens is it gets scooped out like this. And so there's this loss of all of this here. And that's in that first second is where most of it occurs. So that's why we check that number. But then you also, it just takes much longer to get all the breath out. Right? If you have COPD, it takes a long time to get all your air out. Sometimes you can't even get it all out. And so that's what we get with the breathing test. In patients who have pulmonary fibrosis, theirs looks like this. It goes straight up and straight down because their lungs are stiff, stiff, stiff. And when they go to breathe out, they can get all their air out in just a split second. It's just that there's not much in there. Okay, so very different results. So the spirometry is how we make, the initial diagnosis of COPD. We take your history. It seems like you might have it. We do the test. The spirometry is abnormal. Okay, now we know you have COPD. We can talk to you about, do you mostly have problems with chronic cough and bringing up a lot of mucus? Maybe you have chronic bronchitis then. You say, "Doc, I don't cough at all. I'm just short of breath." And we get this, then maybe we'll do a CAT scan and it'll say you have emphysema. Okay? And that's how we sort of delineate some of that stuff. All right. What questions do you guys have about the testing and the diagnosis?
What if you don't follow either one of those? Like you don't have chronic cough, the gassy interstitial emphysema, but you can never breathe.
So then that we would refer to as a chronic bronchitis, would still be chronic bronchitis if you were really going to diagnose this, if you're really going to put it in there. But that does happen. You're not alone. You might not have emphysema, but we have your breathing tests and we know they're abnormal, and you have COPD, but you don't make a lot of mucus and stuff like that. That is not uncommon at all. So you still have COPD, and you're right, you don't easily fit into one of those categories. But if by default we would put you in chronic bronchitis. Does that make sense?
Is bronchiectasis also considered chronic bronchitis?
Bronchiectasis is a little bit different. You can have, they often go together. Bronchiectasis specifically means that your airways, which should be very narrow, have widened and scarred and don't work the way they should. That's a specific finding in certain patients. People with bronchiectasis often have chronic bronchitis type symptoms, but they're not strictly the same thing. Other questions?
The nurses here have all explained this to me, but I still don't understand it. My oxygen level that they measure 4 or 5 times during class, 100%.
Is normal, yes.
And then I can't walk 10 feet without gasping for air.
So,
In other words, I can't walk from you to me right now without being out of breath.
that's how it works. So when we are short of breath, it is not, our brain does not tell us we're short of breath because of our oxygen. Okay? So you got your oxygen, O2. When you are short of breath, it's because your brain doesn't like your carbon dioxide level. So the way the brainstem functions and the brain works is shortness of breath is not related strictly to oxygen level. That the majority of symptomatic shortness of breath that people have is because their CO2 level is high. When your CO2 level goes high, it tells your brain, I'm short of breath and I need to breathe. Anybody in here, and the nurses, respiratory therapists, they might not have any lung problems, but if they run far enough, fast enough, they will get short of breath. And they will feel short of breath because if I poke their blood, their CO2 level was increasing. Okay? Our body is very strict. Everybody's normal CO2 level should be 40. Many of yours is not because of COPD and everything like that. But anybody who doesn't have COPD and is in here right now, their CO2 level is probably 39, 40, or 41. Somebody could be a 38 or a 42, but I doubt it. Our body is very strict about this. When you go to exercise, that number goes up. It doesn't have to go up very much for you to say you're short of breath. If you take a normal person and you make their CO2 45, they will be huffing and puffing. They will be short of breath. So when you are walking, your CO2 level, because of your COPD, is going high. Why is your CO2 level going high and why are your guys? It's because you can't move the kind of air that you want. You're just not moving a lot of air. And also with the COPD, a lot of the air is trapped. You have air trapped in your lung. There's a lot of your lung that has air in it that's not moving back and forth. It's not breathing out. It's just stuck in there. And in medical, we call that dead space because that space of air is not participating. And so the breathing is not as efficient as it should be, and you can't get rid of the CO2, and you get short of breath. Oxygen only gets people short of breath when it's really bad. It has to really fall apart. Most people acutely, if their CO2 is good, you can get their oxygen levels down to 85% or sometimes even lower, and people won't necessarily feel short of breath. It's the CO2 that drives the shortness of breath. So activity burns calories, and when we burn calories, we make CO2. So when you're doing stuff, you're making more than you are just sitting there, and then that triggers shortness of breath. If the more CO2 you're making, you can't get rid of, then you get short of breath. Sometimes it gets to be so bad that you're short of breath even sitting there, and that's because you are working to breathe off the CO2 just sitting in your chair.
That's actually the only thing that helps me is to sit down.
And the reason why sitting down helps is because you're not burning as many calories and you're not making as much CO2, so you don't have to move as much air to keep your body where it wants to be. Okay.
Well, this might sound kind of a silly question. So if the CO2 is treating the issue, why do they treat people with breathing issues with oxygen if their oxygen level stays stable?
So the CO2 is the issue. The CO2 is the issue. So moving on to therapy, well, why don't we talk about some of the therapies of the drugs? And the first therapy we'll talk about is oxygen. Okay, so what is the role for oxygen in COPD? We have a few people on oxygen here, but not all. And the criteria for using oxygen is if your oxygen level, when we check it, is below, sort of cutoff would be sort of 88 to 90%. Okay? If your oxygen is above 90% without any oxygen, you really don't need to be on oxygen. Now, some people, their oxygen level will be over 90% when they're sitting, but if they start to move, it'll go lower. And then we recommend that they be on oxygen. So your question is, okay, if I'm not on oxygen, my oxygen is, 85%. But I'm sitting there, not on my oxygen, and I'm 85%, and I don't feel short of breath. Is that what you're getting at?
Well, no, just the way you explained it before, is the CO2 is the main component of the breathing issues. So that's why I was wondering, you were saying that oxygen would be down to 85 and you're not feeling short of breath, it's not really an issue for your body.
Well, it's not an issue for shortness of breath. That doesn't mean it's not an issue for your body. So being at 85 or 80% all the time does not make you short of breath, but it's very stressful on your heart. So it causes changes to the way your heart pumps blood into and out of the lungs. It can lead, low oxygen levels can lead to what we call pulmonary hypertension, which is everybody gets their blood pressure checked here and they just say that's your blood pressure. That's your systemic blood pressure. There's another blood pressure between your heart and your lungs. That's your pulmonary blood pressure. That can go up. If that goes up, it's kind of a vicious cycle where it leads to lower oxygen and more shortness of breath. And if you get a high pulmonary blood pressure, you can start to get a lot of swelling in your ankles and retaining fluid, and it can be a big problem. So the oxygen often doesn't make people feel better, but it's protective for the heart. Now some people, they do get low enough, and it is enough that they'll notice that I do feel better when I'm on my oxygen. So it can be low enough that it can start to affect the shortness of breath, but it's important to know that shortness of breath is primarily driven by carbon dioxide levels, and the oxygen only kicks in if it's really bad. Make sense? But the oxygen is necessary, and we know that if we have somebody with bad COPD and their oxygen is low, and we take one person and we never give them oxygen, and we take another person and we give them oxygen, the person that we give oxygen will live longer because the oxygen is helping to protect their heart and some of those other parts. Okay. So that's oxygen therapy. Okay. The other big one, obviously, is inhalers. So I hope most of you who have COPD in the audience are either on an inhaler or at least have tried some. Yeah, what are some of the inhalers that people are on?
Albuterol,
You got Advair, Symbicort, Spiriva. Yep, those are all right. Advair, Symbicort, Ventolin, Dialto, Spiriva. Yep, those are all them. Okay. So we're going to break it down. There are three main. Go ahead. Flovent. There are three main categories. We're going to break them down. So one of them is steroid. Next one, what we call beta agonists. Bronchodilator. And then the last one, anticholinergic. So there are three basic categories to the inhalers. Okay, so one of them is an inhaled steroid. So inhaled steroid is Flovent, an inhaled steroid is Asmonex, an inhaled steroid is Qvar. Those are all steroids similar to prednisone that you inhale into the lungs. The steroid's main role in the lungs is a steroid is anti-inflammatory. It decreases the amount of inflammation in the airways. All of these medicines have the same goal. It's you have an airway, and in COPD, the airway is either collapsing as you breathe out or it's thickened and inflamed. So the airway diameter gets smaller. So you go from this to this. All of these medications, the goal is to get this back up, okay? And they just do it in different ways. So the steroid decreases inflammation. It tends to be very helpful in asthma because patients with asthma have a lot of inflammation. Also can be helpful in chronic bronchitis and everything because there is a fair amount of inflammation there. The steroids tend to be less helpful in emphysema. It doesn't mean we never use them in emphysema, but they tend not to be as effective. Okay. The beta agonists or bronchodilators affect the muscles in the airways. They tell the muscles in the airways to relax. And when they relax, the muscles get open up and the airway gets bigger. Okay? So these are Ventolin, ProAir, Proventil. Those are all Albuterol. Albuterol is the oldest respiratory drug we got and is sort of the original and the standby, and it's still what we call the rescue inhaler for all of you. And you can get it in the inhaler, you can also get it in the nebulizer. Different companies make it and they give it under different names. So that Albuterol also has long-acting cousins. They all end with all, and it's usually R, Albuterol. They all end with the same suffix. That's how you know they're similar drugs. So Advair has the key ingredient in Flovent, and it also has another drug called Salmeterol, and again there's that Erol, that is a bronchodilator. So it combines the steroid and the beta agonist together into one inhaler. Okay, that's the same as Brio, that's the same as Symbicort, that's the same as Dulera. Those are all combinations of steroids and a beta agonist, which is a muscle relaxer. So it's an anti-inflammatory and a respiratory muscle relaxer. That's what that's what Brio, Dulera.
Complement is?
Huh?
Complement come under that?
Combivent is different. So that brings us to the last category. Combivent includes Albuterol and another medication called Ipratropium, which is an anti-cholinergic medicine. It also causes the muscles to relax, but it works a different way. It blocks something called acetylcholine, which can constrict the muscle. So it also is a different type of muscle relaxer. The bronchodilator activates part of the muscle to tell it to relax. The anticholinergic blocks a messenger that tells the muscle to constrict. So they work in different ways, but they accomplish a similar goal. So Combivent is really designed to relax those respiratory muscles because it includes the albuterol that tells the muscle to relax, and it blocks the thing that tells the muscle to contract. Okay? So Combivent is a combination of those two medications. It's a short-acting version of that. Stiolto and Anoro are essentially long-acting versions of Combivent. They do these two things with a long-acting drug. Okay? Spiriva and Incruz and Tudorza are all a long-acting version of this, of just that drug. Okay. So, in some patients, we have people on all three. So we have them take Advair and Spiriva, or they take Stiolto and Flovent. So they're getting all three drugs. Albuterol and Flovent would be two of the drugs. You have Flovent, the steroid, and Albuterol is the short-acting version of that, of the bronchodilator. You'd be on two of the three. You'd be missing. You wouldn't have that part. You'd have to add Spiriva or Incruz to be on all three. So it used to be just until a few years ago that if you had a new patient and they had COPD, there really wasn't a lot of recommendations from the greater lung societies about which medicines to use first, in which order, and where to go with them. There was a lot of, we knew in asthma that you always wanted to add the steroid first, and then you would go from Flovent to Advair if they weren't controlled and some other things, but we didn't have that for COPD. That's changed within the last year or two. And now the recommendations are to start with either the anticholinergic alone or the combination of these two. So if a new patient walks in and they have a new diagnosis of COPD, whether it's emphysema or chronic bronchitis, if it's decently bad, the usual recommendation is to start on Stiolto or Anoro. If it's not too bad, sometimes we'll just use the Spiriva or Incruz, which is just this part. I usually will start them on, now more and more, on the Stiolto or the Anoro, or good Lord, they are pushing Bipap on us in the clinic, which is another one. Go ahead.
Do any of these inhalers affect the mucus?
Do they affect the mucus? The anticholinergic can lead to a little less mucus, has another part of its effect, and the steroid can lead to less mucus by decreasing inflammation. The bronchodilators really don't affect the mucus at all. Good question. Other questions about the inhalers right now? They can help loosen it, that you can cough it up by opening the airway up. That's true. So those are the recommendations. In practice, I do see a lot of white hair in here, which means that a lot of you are on Medicare and have Part D. And a lot of the Part D coverage plans leave people with a lot of out-of-pocket costs on these inhalers. And so in some of these cases, like for example, the Stiolto and the Anoro and the Bipap are all pretty new, the combinations, and so they can cost a lot. The Spiriva has been around a little longer, so it's sometimes a little cheaper, so sometimes we'll use that instead. Sometimes they can be so expensive for people that we'll get to having them just do the nebulizer treatments. So like the Duaneb, if any of you ever, is the same thing as Combivent, but in a nebulizer. And the nebulizer treatments are more of a hassle, but are much less expensive than the inhalers. I could go for a whole hour about the costs of the medications and things to do about them, but that is a realistic issue, and it does have, we don't work in a perfect world where I can just give people whatever I want. We have to do things that can make it so people can, aren't broke. Other questions about the inhalers? Yes?
With the inhaler versus the nebulizer, do they do about the same amount of good? It's just,
yeah, if you
inhalers are convenient, nebulizers.
Right, so up until a point, the inhalers work just as well as the nebulizers. So in the vast majority, the inhalers are as effective as the nebulizers. When you start to get really severe emphysema or really severe bronchitis, where it becomes hard, where you're really not moving much air, I start to worry about, are they able to get the inhaler down into the lungs where it needs to be? And in some of those patients, I'll say, we're going to forget about the inhalers now, and we're just going to have to do the nebulizer because I worry about the drug delivery. So that does happen. That's also why in a lot of patients, especially if they have, moderate or severe COPD, if they are doing their inhaler, we give out those spacers. Anybody have a spacer? Because the spacer helps with getting the air down, getting the drug down where it belongs. Go ahead.
Okay, I have a vest.
You have a vest, yes.
I call it the shaker.
The shaker, yes. Shake and bake.
Yes. I do 25 minutes
Yep.
twice a day.
Yep.
Now, what do you think of those?
Yeah, so before we move on to any other questions about the inhalers?
Oh, sorry.
No, we're coming right to you. It's another good segue. Good national segues here, I like it. Okay. So non-inhaler treatments include the vest, the flutter valve. Anybody here got an aerobica? That's good. Anybody got a pickle? You got an aerobica. So you got the flutter valve. So the flutter valve, the aerobica is one brand, and the other brand is called an acapella. People will often refer to the acapella as a pickle because it's green and cylindrical. I think it looks more like a duck call, personally, just a lime green one. These are designed to break up the mucus and help you cough it out. These in general are what we call chest physiotherapy treatments. They're designed to help the thick mucus get broken up into parts that you can actually cough and get out, because if it gets too thick and too tenacious, it'll just plug those airways and the mucus won't move, and then the lung behind that mucus isn't doing anything because it's not getting any air. And so these are all designed to help break out the mucus and help you get it out. So the vest is one, flutter valve is one. Go ahead.
Is that like coping used to do on cystic fibrosis?
Yes, so that is so you're talking about what we call actual manual chest percussion. Some of the respiratory therapists may have done this in the past or still do it. That is the same thing. The vest is a electronic version of that. So a lot of the cystic fibrosis patients now have the vest instead of getting manually percussed. They still do manual percussion when some of the cystic fibrosis patients are in the hospital, at the university, because sometimes the old ways are still the best ways if you can do them. But it's obviously, you need to have somebody to do it rather than you can just have the vest at home.
Now, they told me if I went to the hospital, we should take my vest.
That's a good advice. Yes, you should bring it. I think we have vests at the hospital. We have a limited number. So if you have your own, it's a good idea to bring it in. Okay. So those are a couple non-drug treatment options. Anybody here have a Cpap or a Bipap? Yes, lots of them. Okay. So who's got a Bipap? You know? He's got a Bipap. Okay, good. So in COPD, so CPAPs are to treat sleep apnea, which is very common. A lot of people have it. I have it. I got a CPAP. In certain patients with emphysema, even if they don't have sleep apnea, if their CO2 levels are getting bad, especially at night, because when we sleep at night, we don't breathe as hard because a lot of those muscles turn off. Their CO2 levels will start to go high. And when your CO2 levels go high, you get sleepy, you get confused, and people often start to twitch, fidget. So they'll use a Bipap to help them breathe at night. And it's a similar thing I'm sure some of you have been in the hospital sick and not breathing well, and they put you on the Bipap because it does some of the work of breathing for you. It helps you breathe in and out with you not having to do all of the work. So that's another non-drug treatment for it. We use the Bipap a lot when people come into the hospital and have a COPD, what we call COPD exacerbation, or like a bronchitis or pneumonia episode. And we use it in certain patients, we instruct them to use a BiPAP every night just for their COPD. And then there's also people who are on BiPAP or Cpap for sleep apnea as well. Go ahead.
Is that different than just, or is that the term for using your oxygen like that?
So supplemental oxygen at night is different.
Okay.
Some people needing oxygen, the order usually goes like this. The first thing that people need oxygen for is at night. Okay? The second thing is usually with activity. Sometimes people's oxygen is okay at night, but not okay with activity. And then the last stage is needing it all the time. Some people need oxygen at night, but don't need it during the day yet. But you wonder, in a few years' time, will they start to need both?
So if you have sleep apnea and COPD, it should be more likely to BiPAP than CPAP.
It all depends. If you do well with your CPAP and everything, then you're fine. But I do find that a lot of patients who have both need a BiPAP. If you have a CPAP and you have COPD and you feel like you're suffocating, then you should get looked at for a BiPAP. And the reason you feel like you're suffocating is because your body is telling you it's short of breath, and our innate, we still have a reaction where if there's something on my face and I'm short of breath, my brain thinks I'm suffocating. Even though you really might be getting oxygen and doing better than if you didn't have it, that initial reflex is still there. That if something's on my face and I can't breathe, something's trying to suffocate me. And you can't sort of turn that off in your brain. Go ahead. I don't know. More specifically, we'd have to look into it. Go ahead.
What is the trilogy used for?
The trilogy is a specific type of BiPAP. So there's BiPAP. BiPAP means bi-level positive airway pressure. So there's 2 levels of air pressure that it's putting in. In a regular BiPAP, the patient breathes on their own, and the machine adjusts the pressure level. One level when you're breathing in, different level when you're breathing out. Okay. The next level above the BiPAP is what's called a BiPAP ST, where you can set the rate of the BiPAP so that the BiPAP will breathe at a certain rate even if the patient is not. And you can also try to set that it will give a certain volume of air instead of just setting the pressure. The trilogy is actually what we call an AVAPS device. So I won't I can't remember the full acronym for that. But the trilogy sets pressures, but the pressures adjust with the goal of giving the patient a certain volume of air. And the trilogy takes data from the patient, so it looks at the previous breaths, and it auto-adjusts the pressures that it's giving to keep the breath at a certain amount and to move a certain amount of air back and forth. So the trilogy is really like a ventilator. I mean, it has the capabilities almost of like the ventilators that we have in the hospital that you would use at home. So it technically is a BiPAP, but it's a BiPAP with more features. The trilogies are used in COPD. You can make an argument that that in the past they've been overused, and that most of those patients would do okay on a BiPAP or a device a little less technically sophisticated than the trilogy. But they're really nice and they work well, and so they've been used a lot. Okay, go ahead.
So if you have a patient that has COPD and their sleep apnea can be managed by the primary care neurologist or pulmonology, pulmonology usually the one that should be kind of managing their sleep apnea?
I mean, we definitely try to. If they're already in with the neurologist, that's fine. I think if you have COPD and sleep apnea, I think that's too much for primary care. Our neurology friends at PCI are good, and some of these cases get complicated, and we have patients seen both in neurology sleep clinic and in the pulmonary clinic. But if it's something that we feel like we can manage, we are happy to handle both of those for our patients and save them, another trip every 6 months to another doctor to review that. But sometimes the sleep stuff gets complicated enough that I have to tap out and send them over to the neurology sleep clinic. Okay. We are running out of time. Briefly, I want to touch on a couple things. Pulmonary rehab is another mainstay of non-drugs that we use, and the pulmonary rehab works well. We do talks where we explain it when you go. Pulmonary rehab is good to a reminder of that when people are short of breath, the lungs are a big part of it, but that also if you are, as you get more short of breath and you get less active, your muscles start to not be in as good a shape, and then they're more demanding, and getting exercise and getting the muscles back into better shape means a lighter load on your lungs. Anybody been to pulmonary rehab? Anybody not like pulmonary rehab?
No, but there's a limit to it.
There's a limit to how much it can do, that's right.
No, there's a limit to how many trips you can do.
There's a limit to how many trips your insurance will pay for. That is true. There is no limit to how many times you can go. There is a limit to how many times your insurance will pay for it.
So I have to do it on my own now.
That's true, yes. The other thing would be, the other thing to talk about would be in our younger patients with COPD and they're needing oxygen and things are going bad at younger ages, we do refer down to the university for the transplant center. People do get lung transplants for COPD. I don't know strict criteria, but if you're over 70, you're out of luck. They want people to be doing a lot of exercise, and it's important that they not, because of the surgery and some of the things that they're very strict about, you can't be overweight. But they do that there, and they do a nice job and have very good outcomes compared to other centers nationwide. So that is an option. Obviously, when people are having exacerbations, you guys all probably know that the mainstays for treating that are using an antibiotic and some form of prednisone or another steroid. I'm sure a lot of you are familiar with that. That's all very well established in the literature that that's how we should treat it. What is not well established is how much prednisone people should be on for these things. There just isn't good data to really say how much you should be on. I tend to go with whatever works for the patients in the past. We go with that. If possible, if at all possible, we do not like people to be on prednisone all the time because it is hard on the bones, it's hard on the muscles, and it is generally not good for you. There are exceptions to every rule, and there are some people that we maintain on a low dose of prednisone, but that is the exception, not the rule. Is anybody here on, go ahead.
The difference between the blood steroid and prednisone.
So the prednisone is an effectively much, much higher dose, like hundreds of thousands of times a higher dose. And so it gets into the lungs and works in the lungs, but it also is affecting other parts of the body. You just can't deliver that much through an inhaler. So it's a much, much higher dose. Is anybody here on an antibiotic every day or 3 times a week? Yes. Zithromycin? Is that what it's
Clarithromycin.
Clarithromycin?
I'm allergic to a lot of antibiotics.
Yep.
I'm very immune.
So that is another sort of non-inhaler thing that we do for people, and that's specifically for people who've had a history of getting bronchitis and infections over and over again. And that's been shown, it doesn't make it so you never get an infection again, but it decreases the rate of that slightly.
And if I get an infection, then I switch to Ceftonir.
And you get a different one. Yep, that's right.
And Prevacid.
Is anybody on Dalaresp? Dalaresp is another separate type of drug that is used in people who get frequent infections. It's very expensive. So it's not much of an option if you're on Medicare.
My mom was on infusions once a month. Their immune system,
That would be different. That'd be sort of different. She probably was getting IgG infusions, which is sort of
lung infection.
right. So that's not technically COPD, but that speaks to if you have COPD, it doesn't mean you don't have other things that we don't need to address.
What is your multi-specialty?
Multi-specialty means that the clinic across the street, we have lung doctors, we have general internal medicine, and we have infectious disease, so that's the office. All right. The last thing we'll talk about is sort of the natural progression of COPD. How does it progress? So if we take anybody's breathing, you sort of max out your lung capacity at around 20 to 25, okay? So we all are 20, 25, we're at the tippy top of our breathing. If you never smoke and you never have any problems, your breathing tests, if we checked you every year, the numbers, like if we go back to like the FVC and the FEV1, what would those numbers be? They go sort of like this. So they go down very slowly, okay? If you were 20 to 25 and you were welding or you were smoking a pack and a half a day and you were one of the unlucky ones who was prone to developing chronic bronchitis or emphysema, we don't know that you're going to have that yet, but if that's the case, if we went back in time and we made you do breathing tests every 6 months, wouldn't that be fun? What we would see is we would see something relatively like this. Okay. So your breathing test would be going down, and it would be going down at a faster rate. Now you could be this curve, that's a real bad one. It could be this one. It all depends on who you are and how much you're smoking or what your other exposures are. But you're going down at a relatively steady and predictable rate during that time. If you stop smoking, you go back to the regular one. You don't go back up. You go maybe up a little bit, but not much. But the main thing that happens is you go back to being on the normal curve, like other folks. Okay. So if you have COPD and you're still smoking, you're still going on this curve. So that's why it's important to quit, because we want to stop that progression. Okay. Once you get down to it, though, once you get here, okay, there's no strict cutoff on that. But you have COPD or have emphysema, and you stop smoking. That's good. So you're going like this. Okay. Now I'm going to give you pneumonia. And you're going to get pneumonia, and you're going to go, and we're going to treat you for pneumonia, and you're going to get better, and you're going to come up. But you're not going to come back up to the line before. You're going to have lost a little bit. And the more of those that happen, the more you lose, and you never quite always get it back. And the more severe the infection or the flare is, the more you're going to lose. So that's why we do the clarithromycin, or we do that stuff. One, you don't want to be sick, you don't want to be in the hospital. Two, if you are sick and something happens, we know you're going to lose more lung function quicker. So that's the progression. And so it's very hard to predict. Once we get down to a certain level, if you quit smoking and you're not getting infected, you can kind of maintain at that level indefinitely. But if we're getting lots of infections, or if you're still smoking, then it tends to progress ongoing.
You say you don't feel you recover completely after the pneumonia?
Yes.
Because in March I was in the hospital.
I don't feel it. That's just a fact. You don't recover completely.
I had viral bronchitis and pneumonia. I was in the hospital for a week.
Okay.
And the doctors there kept telling me that once you recover from this, get your strength back, go through the rehab, your lungs will be just the same as they were before.
I don't know who told you that, but they're alive.
Hospitalist here, Dr. Cruz.
Sorry, not true.
Our children came from out of state to the conference with him.
He was very good, he spent time with us.
I mean, you can get close, but not true. I mean, if we looked at the numbers of your breathing, they would not get back to the same.
I've come a long ways, but nowhere near what it was before.
They did tell us that we had the Prevnar 13,
Mm-hmm.
and that say we were in a car accident, and our primary caregiver said that we should have that shot,
Mm-hmm.
and they told him that saved him, because he had is it pneumococcal pneumonia?
Mm-hmm.
Yeah.
Maybe, I don't know.
That's what he was told.
I mean, we definitely recommend that the recommendation is for anyone over 65 to get both the Prevnar and the Pneumovax, and to get your yearly flu shot. It's vitally important in all of our patients with COPD that they get their vaccinations. That said, they are not foolproof, but it's better to get them than to not get them. That's very clear. Go ahead.
There's a new one.
Yeah, the new one, for most of you, most would probably qualify for what we call the higher dose for the elderly is recommended. Okay. Last chance for questions. We gotta wrap it up.
Are you accepting new clients now?
We are accepting new clients. We have 2 new doctors with the group, which has helped. I don't know if any of you noticed, but we were booking patients way out in advance for a while.
He was assigned to Dr. Painter,
To Dr. Painter,
but we don't know who he's got now.
I don't know yet either.
I guess I'll
I've
read
been
home.
sending a doctor down to Rapids Hospital.
Okay.
City.
Oh yeah, who's that?
Gowan.
Dr. McGowan.
Lynn McGowan.
Does he still wear outer sandals? Do
Yes, he does.
Sandals and socks in January.
Yes, he does. He's a very nice man.
Yes.
Problem being, if I'm in the hospital here, he's down there.
That's right.
I need to get somebody there.
Yep. Yes, so we are accepting. We are back up to 6 docs. You know, there were 7 in the Cedar Rapids. Well, there's more than that. There's Mercy too. But there were 7, working at St. Luke's here, a year ago. And we got down to 4 for a little while, which is why we got kind of behind, but we're back up to 6. So we are seeing new patients, and it's not as long a wait as it used to be.
I've got one question.
Go ahead.
Probably no answer to it.
Uh-huh.
I went to Dr. Cowden here. He's no longer in town.
Correct.
And asked about getting a CT scan, because I got on the lung study down at University Hospitals.
Mm-hmm.
And he said, no, I won't give you a CT scan. He said, I'll put you on a stress test.
Okay.
So he put me on a stress test.
Okay.
And I thought I could do it. But he pushed me too hard at the last. I lost my breath completely.
Uh-huh.
I kept telling me, take it off, take it off. He turned around and just calm and said, oh, just keep going, just keep going. You only got 15 seconds more. And I kept going. I got all done. I couldn't breathe. I fell off the back. I sit down on all those cords and everything that I hooked up.
Uh-huh.
And he turned around and just calm as could be and said, nothing, trying to catch my breath.
Okay.
He turned around and just calm as could be. He said, your blood oxygen levels are good at your heart. Walked out and left me.
So consequently, he went, it wasn't
Down
his
to
heart.
University Hospital and check out.
Yeah, I probably wouldn't have advised doing that pulmonary stress test.
But they put all the heart tests on me, but nothing wrong with my heart.
Yeah, I mean, so what you're sort of getting at is shortness of breath can be heart related, it can be lung related, it can be related to low oxygen and being deconditioned. The heart doctors, I think, are notorious for saying there's nothing wrong with your heart. What they mean to say is there's nothing they can do to fix it often, and that it is where it is, and that you're on the right medications to do it as good as it is. But they'll often say that there's nothing wrong with your heart, which is not true. But it's not to say that, you know, it is complicated.
Even on the catheter test, so there's actually no cholesterol, and so the
Yep.
heart looked like somebody in their mid to late 30s.
Well, that's good.
It was.
Okay.
I've heard that. Did I get
Go ahead.
that on breath?
When I had a supraventricular tachycardia,
Mm-hmm.
and I landed in the hospital, of course, and they did an ablation on me. Now, when I went in, I did not have oxygen. When I come out, they said it was because that it's common to happen with certain because of surgery, and I've been on oxygen ever since. Why is that? I mean,
I would have to see in your chart to do it. In general, those ablations, they're burning the atria and the blood vessels around there to get rid of the supraventricular tachycardia. And so they're burning there. You can cause some scar tissue. And if you remember, circling back to when I was talking about the pulmonary hypertension, that procedure can be associated with a mild, in some cases severe increase in pulmonary hypertension, which can lead to needing oxygen. So that is not unheard of, to get that procedure and to then need oxygen or have lower oxygen after it.
well, when they went in, they thought it would be just simple and it would be a short time, and they found another spot.
Yeah, and the more they have to do, the more risk there is of that.
Okay.
Okay,
Well, thank you, Dr. Lindsay.
thank you.